You see, uh, VT recurred after potassium correction. So now what will you do? You will re-examine for this QT prolonging drugs. You will see whether there are QT prolonging drugs going on, and check magnesium and serum calcium, and you will correct such things aggressively. You will consider lidocaine if ongoing ventricular arrhythmia with prolonged QT, and you will avoid amiodarone if clear torsade is depoint physiology is seen. Now, for instance, if an imaging shows 1.5 centimeter unilateral nodule, can we skip AVS? So only consider skipping AVS if, as already mentioned, greater than 35 years age, with triad, and with this kind of nodule. There should be all solitary adenoma. Then you can avoid AVS. So second thing is, does ablation have a role? You see, thermal ablation for aldosterone producing adenoma remains investigational, but standard of care is surgery in case of unilateral disease and mineralocorticoid receptor antagonist in case of bilateral diseases, and this is a guideline stance as per Oxford Academic. This is one thing we mentioned, that in Conn syndrome, what we see is hypokalemia. So is it common? You see, hypokalemia is not universal in primary aldosteronism mechanisms. For instance, aldosterone action. Aldosterone promotes sodium reabsorption, potassium excretion in the distal nephron, principally via these channels, ENaC and ROMK channels. So ENaC and ROMK channels are present in the distal nephron. This is outer medullary potassium channel. So where this potassium secretion is done, and whether this leads to frank hypokalemia depends upon dietary potassium intake, also renal handling, and degree of aldosterone excess. So three things are there is an interplay of three things. One is dietary potassium intake, renal handling of potassium, and degree of aldosterone excess. So factors balancing potassium. You see, many patients have adequate dietary potassium intake that offsets urinary losses. So even if aldosterone is causing potassium excretion via ENaC and ROMK channels, but adequate dietary potassium intake is there that offsets urinary losses. Also, if patient has early or mild disease, that may not overwhelm renal tubular adaptation. Third is, some individuals have genetic or renal tubular variation in handling potassium. Fourth is use of, for example, ACE inhibitors, ARBs. The patient is on beta blockers that can blunt potassium wasting. For instance, patient is hypertensive, as we know, and he is taking, for instance, ACE inhibitors for its treatment, but the disease is because of primary aldosteronism. You see, potassium can be normal in such an individual. So multiple factors are playing role here. So clinical data, as historically primary aldosteronism was described as hypertension with hypokalemia, but we know now that normokalemic primary aldosteronism is more common than hypokalemic, and incidence of normal potassium is 60 to 80%. They are normokalemic at diagnosis. Always remember this thing. So 60 to 80% are normokalemic at diagnosis, and only remaining 20 to 40% are present with hypokalemia. So hypokalemia is more likely in, one is this severe long-standing and unilateral adenoma cases. So severe hypokalemia will be seen in 20 to 40% of the cases, and that too in severe, long-standing, and unilateral adenoma cases. And this is as per Endocrine Society Clinical Practice Guidelines 2016. And although aldosterone promotes renal potassium wasting via ROMK and INEC channels, but most patients, that is 60 to 80% present with normokalemia. That's about 2/3 of the patients. It's because of dietary intake, it's because of renal adaptation. So as we already discussed, dietary intake of potassium, renal adaptation, so and degree of aldosterone excess, renal handling, genetic variations, and the presence of the drug history like ACE, ARB, beta blocker intake. So somewhere we discussed VT and this polymorphic ventricular tachycardia, that Torsades depoints, and this is because of triggered activity, whereas this is due to QT prolongation. So what is triggered activity? Triggered activity is an abnormal depolarization of cardiac cells that occurs after an action potential due to after depolarization. So it is due to after depolarization. So it's a triggered activity. It's triggered by an action potential due to after depolarization. These can reach threshold and generate premature action potentials leading to arrhythmia like VT or Torsades depoints. So there are two types: early after depolarization and delayed after depolarizations. So these are the two types that cause triggered activity and eventually leading into VT or Torsades depoints. As we already mentioned, there are two mechanisms for development of arrhythmias. One was hypokalemia, hypomagnesemia induced. Another was because of this arrhythmogenic substrate that is produced because of remodeling due to presence of long-standing hyperaldosteronism, and eventually this VT occurs due to either triggered activity, and Torsades depoints occurs because of this that is prolonged QT interval or things like that. And triggered activity is simply this triggering of action potential when it reaches threshold. That is I mean early after depolarization, delayed after depolarizations. So in Conn's, hypokalemia and prolonged repolarizations, because hypokalemia, what it does, it prolongs repolarization. So because of hypokalemia and because of prolonged repolarization, it predisposed early after depolarizations, which are a form of triggered activity. These after depolarizations can reach threshold and trigger VT. So one is hypokalemia, another is prolonged depolarization. So this predisposed early after depolarization, which are a form of this triggered activity, and these are simply early after depolarization like this, but when they reach this threshold, they can cause VT.